Treatment of Cushing's syndrome. Vanian MD, transfen oil surgery. Surgical management. Transfen oil surgery. Transfen oil surgery (CES) is widely regarded as the treatment of choice for Cushing's disease. Transfen oil surgery. The overall remission rate in various large series is in the order of 70% to 75%, although higher rates of approximately 90% can be achieved with microadenomas. About 25% of these will have a recurrence by 10 years. This emphasizes the need for long-term follow-up. Prognostic markers of long-term remission. Prognostic markers of long-term remission are: patients aged over 25 years, a microadenoma detected by MRI, lack of invasion of the dura or cavernous sinus, histological confirmation of an ACT-secreting tumor, low postoperative cortisol levels, long-lasting adrenal insufficiency. Adenomectomy versus hemihypophysectomy. Where an adenoma is apparent at transvenoidal exploration, a selective adenomectomy is performed. Where no tumor is obvious, a hemihypophysectomy as guided by the biopsy results is often the best course of action, hopefully achieving cure without panhypopituitarism. Where remission is not achieved at the first operation, a reoperation may be attempted, but appears to offer prolonged remission in only around 50% of cases, and with a high risk of hypopituitarism complications. There is limited data on endoscopic pituitary surgery for Cushing's syndrome. The perioperative mortality was 1.9%, with other major complications occurring in 14.5%. The frequency of reported adverse events varies widely. Diabetes insipidus, either temporary or permanent, 3% to 46%, hypogonadism, 14% to 53%, hypothyroidism, 14% to 40%, cerebrospinal fluid rhinorrhea, 4.6% to 27.9%, severe growth hormone deficiency, 13%, bleeding, 1.3% to 5%, and meningitis, 0 to 2.8%. Postoperative evaluation and management. It is usual to give glucocorticoid cover for transven oil surgery at initial daily doses of up to 400 mg hydrocortisone, 4 mg dexamethasone, tapering off within 1 to 3 days. Morning, 9 a.m. Serum cortisol measurements are then obtained for 3 days starting 24 hours after the last glucocorticoid administration, during which time the patient should be observed for development of signs of adrenal insufficiency, the best indicator of remission. Postoperative hypocortisolemia, less than 15 mol/L, 1.8 micrograms/dL, at 9 a.m., is probably the best indicator of the likelihood of long-term remission. However, detectable cortisol levels of less than 114 mol/L, less than 5 micrograms/dL, are also compatible with sustained remission. Failed surgery. Higher postoperative cortisol levels are more likely to be associated with failed surgery. However, cortisol levels may sometimes gradually decline over 4 to 6 weeks, reflecting either gradual infarction of remnant tumor or some degree of adrenal semi-autonomy. Persistent cortisol levels greater than 114 mol/L, greater than 5 micrograms/dL, 6 weeks after surgery require further investigation. CRH test. The CRH test in the early postoperative period in patients with hypocortisolemia and apparent cure may provide a useful index of the risk of recurrence of Cushing's disease. The rationale being that responsiveness may indicate residual tumor. Persistent hypercortisolemia. Persistent hypercortisolemia after transvenoidal exploration should prompt re-evaluation of the diagnosis of Cushing's disease, especially if previous diagnostic test results were indeterminate or conflicting, or if no tumor was found on pathological examination. Treatment options. The treatment options for patients with persistent Cushing's disease include repeat surgery, radiation therapy, adrenalectomy. Early repeat transvenous oil surgery including the endoscopic technique may be worthwhile in a significant proportion of patients, at the expense of increased likelihood of hypopituitarism. Repeat cellular exploration. Repeat cellular exploration is less likely to be helpful in patients with empty cellular syndrome. Very little pituitary tissue on MRI scans. Patients with cavernous sinus or dural invasion identified at the initial procedure are not candidates for repeat surgery to treat hypercortisolism. Should receive radiation therapy. Hypocortisolemic patients. Patients who are hypocortisolemic should be started on glucocorticoid replacement. Hydrocortisone 20 mg total daily dose in 3 divided doses is the preferred choice. The largest dose, 10 mg, should be taken before getting out of bed, and the last 5 mg dose should be taken no later than 6 p.m. Information bracelet or necklace. They should also obtain a medical information bracelet or necklace that identifies this requirement. Education should stress the need for compliance with the daily dose of glucocorticoid, the need to double the oral dose for nausea, diarrhea, and fever. The need for parenteral administration and medical evaluation during emesis, trauma, or severe medical stress. Recovery of the HPA axis. Recovery of the HPA axis can be monitored by measurement of 9 am serum cortisol after remission of hydrocortisone replacement. Because recovery after transvenous oil surgery rarely occurs before 3 to 6 months and is common at 1 year, initial testing at 6 to 9 months is reasonable. If the cortisol is undetectable on 2 consecutive days, then recovery of the axis has not occurred and glucocorticoid replacement can be restarted. Reserve of the HPA axis. If the cortisol is measurable, adequate reserve of the HPA axis can be assessed using the insulin tolerance test, with a peak cortisol value of greater than 500 mol/L, greater than 18 micrograms/dL, indicating adequate reserve on modern assays. Many centers use the cortisol response to 250 micrograms synthetic, 1 to 24, act as an alternative means of assessing HPA reserve. Glucocorticoid replacement can be discontinued abruptly if a 30-minute cortisol of greater than 22 micrograms/dL is probably more reliable. Glucocorticoid replacement can be discontinued abruptly if the cortisol response is shown to be normal. If cortisol levels are above the lower limit of the normal range at 200 mol/L, 7 micrograms/dL, it is reasonable to taper and stop the hydrocortisone unless symptoms of adrenal insufficiency occur. Adequate replacement. Assessment of adequate replacement of hydrocortisone dosing by measuring serum cortisol at various points throughout the day, ensuring that levels are always sufficient, greater than 1.8 micrograms/dL, before each dose is useful. In the future, modified release hydrocortisone may provide more physiological replacement. Recurrent Cushing's syndrome. Patients who articulate that the Cushing's syndrome has returned are often correct. Investigation is warranted in a patient with these complaints or with recurrent physical signs characteristic of hypercortisolemia. UFC can be measured initially on dexamethasone 0.5 mg/day, if not yet weaned from glucocorticoids. Measurement of late-night salivary cortisol having omitted the afternoon dose of hydrocortisone may also be useful. Recurrent Cushing's disease. If recurrent Cushing's disease is diagnosed, the therapeutic options are the same as for persistent disease. The patient who has a subnormal cortisol response to ACT 2 years after transvenous oil surgery, in the absence of over-replacement, is likely to proceed to lifelong ACT deficiency. Post-operatively, assessment for deficiencies of other pituitary hormones should also be sought, and the appropriate replacement regimen initiated as necessary. Diuresis. Diuresis is common after transvenous oil surgery and may result from intraoperative or glucocorticoid-induced fluid overload or may be due to diabetes insipidus. For these reasons, assessment of paired serum and urine osmolality and the serum sodium concentration is essential. Diff. It is advisable to withhold specific therapy unless the serum osmolality is greater than 295 mmosm/kg, the serum sodium is greater than 145 mmol/L, and the urine output is greater than 200 ml/hour with an inappropriately low urine osmolality. Desmopressin, DIP, ferring 1 microgram given subcutaneously will provide adequate vasopressin replacement for 12 hours or more. Hyponatremia. Hyponatremia may occur in as many as 20% of patients within 10 days of surgery. This may be due to injudicious fluid replacement or the syndrome of inappropriate antidiuretic hormone secretion, SIAD, as is frequently seen after extensive gland exploration, and fluid intake should be restricted. Adrenalectomy. Adrenalectomy is the treatment of choice for all cases ACT-independent Cushing's syndrome. This is either unilateral in the case of an adrenal adenoma or carcinoma, or bilateral in cases of bilateral hyperplasia. In adrenal adenomas, cure following surgery in skilled hands approaches 100%. Adrenal cancer. In adrenal cancer, more aggressive operations to resect primary lesions, local recurrences, and hepatic, thoracic, and, occasionally, intracranial metastases, and is usually accompanied with adjuvant mitotain is needed. Laparoscopic adrenalectomy, both unilateral and bilateral, has been shown in experienced hands to be a safe procedure and in many centers has become the approach of choice for non-malignant disease. Bilateral adrenalectomy. Bilateral adrenalectomy is also an important therapeutic option in patients with ACT-dependent Cushing's syndrome not cured by other techniques, particularly in young patients desiring fertility where there are concerns over radiotherapy-induced hypopituitarism. It has the disadvantages of lifelong glucocorticoid and mineralocorticoid replacement therapy, and increased perioperative morbidity and mortality. In addition, the development of Nelson's syndrome in patients with ACT-secreting pituitary adenomas occurs in between 8% and 38% of cases. Nelson's syndrome. The chance of developing Nelson's syndrome appears to be greater if adrenalectomy is performed at a younger age, and if a pituitary adenoma is confirmed at previous pituitary surgery. Prophylactic pituitary radiotherapy probably reduces the risk of developing Nelson's syndrome. Others have advocated unilateral adrenalectomy plus pituitary radiation as an alternative to bilateral adrenalectomy, as it gives similar remission rates to primary transvenous oil surgery. Surgery for the ectopic ACT syndrome. If the ectopic ACT-secreting tumor is benign and amenable to surgical excision, such as in a lobectomy for a bronchial carcinoid tumor, the chance of cure of Cushing's syndrome is high. If significant metastatic disease is present, surgery is not curative although it may still be of benefit in selected cases. In this situation, bilateral adrenalectomy may be an option if medical management fails. Radiotherapy. Conventional pituitary radiotherapy is delivered at a total dose of 4,500 to 5,000 centigrades in 25 fractional doses over 35 days using a 3-field, opposed lateral fields and vertex field technique. The complications of optic neuritis, cortical necrosis, other anterior pituitary hormone deficiency in over 50%, increased risk of cerebrovascular complications, meningiomas and gliomas, gamma knife radiosurgery. With gamma knife radiosurgery achieves biochemical remission in about 55%. Medical management. Pre-treat Cushing's syndrome patients prior to surgical treatment. In patients with Cushing's disease whilst waiting for pituitary radiotherapy to take effect. In patients where surgery and/or radiotherapy has failed. As a palliative modality in patients with metastatic disease causing Cushing's syndrome. Medical therapy. Metoprolol ketoconazole mitotain adrenalytic. etomidate. Other medical agents: octreotide, pasireotide. Pasireotide combination therapy with cabergoline and ketoconazole. Temozolomide. Retinoic acid. Thiazolidinedione. Mifepristone. Monitoring treatment. It is important to monitor all patients on medical therapy for Cushing's syndrome, to assess the effectiveness of treatment, and in particular to avoid adrenal insufficiency. We use the mean of 5 serum cortisol measurements across the day. A mean serum cortisol between 150 and 300 mol/L, 5.5 to 11 micrograms/dl, corresponds to a normal cortisol production rate, and this range should be the aim of therapy. Ketoconazole. The most commonly used agent is the antifungal drug ketoconazole, which has a rapid onset of action but is frequently associated with loss of control of hypercortisolism, a phenomenon known as escape, owing to ACT oversecretion. Mitotane. Mitotane is a potent drug with delayed onset but long-lasting action, and it is not associated with escape occurrence.